tonight.
I went to the doctor for my annual visit.
So I was pregnant, and at one of my routine OB appointments,
She said, wow, your thyroid's really inflamed.
the nurse practitioner palpated my neck and just said, well, I do feel a lump.
I'm sending you for an ultrasound.
An ABC 27 special presentation.
So then they did a biopsy.
The doctor said
That came back as being positive for
thyroid cancer.
Thyroid Cancer, a matter of fact. Sponsored by Penn State Cancer Institute.
Good evening, I'm Deborah Pinkerton. September is Thyroid Cancer Awareness Month. According to the American Cancer Society, there will be more than 62,000 new cases of thyroid cancer in the United States this year. Nearly 3 out of 4 cases of thyroid cancer are found in women. In the United States, incidents of thyroid cancer have tripled in the last 30 years. Pennsylvania has the highest number of cases in the entire country. Why is thyroid cancer on the rise? Is thyroid cancer hereditary? Well, you will find out tonight. A Berks County woman went to the doctor for a routine visit when she was 3 months pregnant. It's a visit she will never forget. Here's Laura Klitsch's journey.
Quit.
No, you can't quit now.
39-year-old Laura Klitsch never quits. She never gives up, even when she receives some disturbing news. She was pregnant at the time with her daughter Laura.
At one of my routine OB appointments, the nurse practitioner just said she routinely checks thyroids and, not to be worried. She just palpated my neck and she asked me, she's like, did you know you had have a lump there? And I'm, no, didn't think anything of it. So then she showed me, I swallowed, and she showed me how the lump, and of course then I saw it.
I recall her telling me about the situation, but to be perfectly honest with you, on my side, it really didn't seem to be that big of a deal to me because she wasn't making it that big of a deal.
I'm not really a quick worrier, so my initial reaction was sort of like, okay, something else to check out. I mean, I was blissfully pregnant. I was happy-go-lucky.
She's the type of person that's very positive and says, you know what, we'll get through it no matter what.
Some tests were scheduled to take a closer look at the lump.
The ultrasound was first just to see how that came up, and that looked suspicious.
When she was found to have a suspicious nodule on ultrasound, a fine needle aspiration biopsy was performed, and this confirmed that she had a papillary thyroid cancer. This is when, like any other cancer, the cells inside the thyroid gland begin to replicate and don't die as they should. Over time, this allows these cells to grow out of control, to spread. Hers had already spread to the lymph nodes in her neck, where papillary thyroid cancer typically spreads first.
Laura found out the results of the biopsy a day before Thanksgiving.
They called me, it was late on I guess it was a Wednesday, on my way home from work, and I pulled over as soon as I knew who the call was from and got the news. And I didn't expect to get super upset, but I did. Because, you hear, okay, it's malignant, you have cancer, not something you want to hear, obviously. So that was probably my moment of, okay, this is real, now what do I do? And I sat and cried for a little while by myself.
When the word cancer was brought into it, that's when it became like, oh my gosh, this is pretty serious.
Some difficult decisions needed to be made.
There were a lot of conversations with my OB, with endocrinologist, and Dr. Goldenberg about whether or not to do surgery while I was pregnant.
It just makes the disease more difficult to treat at that point in time because we not only have to take the mother's well-being into account and to get rid of her thyroid cancer, but we also have to take the fetus's well-being into account. And it was decided in her case that we would monitor her with ultrasound, which is safe for the fetus and the mom because it has no radiation, and we would proceed with surgery after she gave birth.
I was very happy about that. I didn't want surgery while I was pregnant. I didn't, unless it was necessary, I didn't want that risk.
Doctors monitored Laura throughout her pregnancy. She gave birth to her daughter Laura in May. 3 months later, she was back in the hospital for a thyroidectomy.
My surgery was planned for August 1st, so probably about a week before that was when I started to get nervous.
Besides the primary tumor in her thyroid gland, she had multiple lymph nodes, both in the central compartment and in the side of her neck, which harbored metastatic disease. That does not negatively impact how well you do, but it does indicate that she would be a candidate for further treatment.
Then they usually recommend radioactive iodine treatment. But because I was nursing and felt strongly about continuing to nurse as long as I could, we delayed radioactive iodine treatment.
Laura waited 9 months to have the treatment.
Radioactive iodine is a targeted radiation therapy that will go and destroy tumor that has not been surgically removed or that may be far away already from the thyroid bed.
The thyroid gland uses iodine as part of the engine that makes that thyroid hormone. And it is unique in the fact that it is the only organ in the body that concentrates iodine. And it doesn't harm other bodily tissues because they do not concentrate iodine.
There is no obligatory hospitalization for patients treated with radioactive iodine, assuming that they have appropriate home conditions, that they do not expose other people to the risk of radioactive iodine.
I had to be in isolation for 3 days. After the initial 3 days, then I could be within like 7 to 10 feet from people. I had a little makeshift apartment down in the basement, and I was just down there by myself.
Some time needed to allow the radioactive iodine to do its job.
I think she pulled through it like a trooper, to be honest with you.
I dreamed a dream in days gone by.
Since thyroid cancer can recur, Laura sees Dr. Manny twice a year.
One of the main goals is to monitor, obviously. The way we monitor patients with thyroid cancer is by two methods primarily. One is to repeat the neck ultrasound. The other method is measurement of thyroglobulin, which is this protein which is produced in the body only by thyroid cells.
No song unsung, no wine untasted.
So far, Laura's tests have been good.
Tigers come at night. I feel like my levels are where they need to be. My energy's back up to normal or close to normal. As they tear your hope apart.
She's doing very well. She's doing very well.
Right now, I feel great. To share.
Laura never suspected she had a problem with her thyroid. She is so thankful the nurse practitioner felt her neck. Joining us now is head and neck surgeon Dr. David Goldenberg. Thanks for being here with us. You brought a model of your neck. Where is your thyroid and what is its purpose?
Well, here you have a model of the front portion of your neck under your skin and muscle. This over here is the Adam's apple in a man, and here is the windpipe. And sitting on the windpipe is this gland that looks kind of like a butterfly. Has two sides and a bridge in the middle, and that's your thyroid gland. The thyroid gland is your body's thermostat. It controls your tolerance to heat and to cold. It makes you tall or short, thin or fat, and it regulates heart rate.
Laura had one type of thyroid cancer. What are the other types?
Well, there are 4 types of thyroid cancer. Papillary thyroid cancer, the type she had, is overwhelmingly the most common type of thyroid cancer. Other types include follicular thyroid cancer, which comprises around 10% of thyroid cancers. And then there's medullary thyroid cancer and anaplastic thyroid cancer, which are much rarer.
And how do you treat thyroid cancer?
Thyroid cancer is primarily treated with surgery. Most of or the whole thyroid gland is removed in conjunction with any lymph nodes that may be involved with the cancer. After that, in many cases, the patient's treated with radioactive iodine, which is a pill or a liquid in a one-time fashion. Chemotherapy and external beam radiation therapy is typically not used or necessary in thyroid cancer.
It seems that your thyroid is an important organ. Tell me, what do you do after it's removed?
Well, we need our thyroid gland, and once it's removed, we treat our patients with thyroid replacement therapy in the form of a pill, which they take once a day to mimic the effects of their normal thyroid.
And it seemed in Laura's case that it was just incidentally found. Are there symptoms of thyroid cancer?
Well, the vast majority of them are indeed incidentally found because there are no signs or symptoms in most cases. Occasionally, the patient or their doctor will feel a lump in the front of their neck where their thyroid is, called a nodule, and that's how it's discovered. More rarely, when the disease has progressed, a patient may feel pain in their neck, they may have trouble swallowing, they may be hoarse, or they may have pain on swallowing or even problems breathing.
What are some risk factors?
There really aren't a lot of risk factors for the development of thyroid cancer. We say being a woman is a risk factor because it affects women 3 to 4 times more often than it does men, and usually that's women of childbearing age. Another risk factor includes exposure to low-dose radiation, either therapeutic or accidental, with a lag time of about 15 years.
Okay, Dr. Goldenberg, thank you.
And I'm here with a specialist you're a surgical oncologist, Dr. Brian Saunders. Thanks for joining us.
Oh, my pleasure, thank you.
And you're going to answer some viewer questions. Sure. We have a viewer question for you. Now, my doctor sent me for an ultrasound of my thyroid, and I was diagnosed with Hashimoto's disease. Does this increase my risk for thyroid cancer?
So Hashimoto's disease is a low thyroid function state. An ultrasound can certainly suggest the diagnosis, but it's really confirmed with blood work showing low thyroid function. It in and of itself does not increase your risk for thyroid cancer.
So you shouldn't be as concerned if you are diagnosed with Hashimoto's disease?
No.
Well,
no.
Thank you for answering that. You're going to answer plenty of more questions coming up.
You're watching Thyroid Cancer, a Matter of Fact, on ABC 27, sponsored by Penn State Cancer Institute.
Welcome back. A Dauphin County woman went to her doctor for her annual exam, a routine visit that turned out to be much more than she ever expected. Here is Janice Shan's journey.
I've been to Italy and we rode a gondola. I went to Paris. We saw the Eiffel Tower and the Mona Lisa, and I continue to have plans and dreams of my next trip.
45-year-old Janice Shan now makes the most of every moment. A doctor's visit changed her way of thinking.
I went to the doctor for my annual visit. It was for a pap test, actually, and the doctor felt my neck just for about a second, and then she said, "Wow, your thyroid's really inflamed." And she felt it again, and she said, "Immediately, I'm sending you for an ultrasound." I remember thinking, okay, yeah, I'll do an ultrasound, you know, like, whatever. Thinking, I'm 36 and I'm healthy. This is weird. I'll just do the test because you're asking me to do it.
I didn't think anything about that until she called to say she had something wrong and had to go and have a needle biopsy. And so I said, okay, you know, try to keep it in like I am now.
They wanted to check it out even further and do an actual biopsy. They had seen something that was suspicious.
Janice asked her doctor to call with the results.
The doctor said it was definitely thyroid cancer. And I remember just being dumbfounded, like not crying. I just was in shock, I think. And I said, okay, well, what do we do next?
A mother's action is always, let's get this fixed.
So Janice and her mother, Pat, met with head and neck surgeon Dr. David Goldenberg, who reviewed her PET scan.
This is her neck region here. As we scroll by, you can see that there's areas that light up throughout the neck, in the middle portion of the neck, as well as the side of the neck and in the chest. All of these are indicative of metastatic papillary thyroid cancer. I explained to her that she had a relatively advanced case of papillary thyroid cancer, and because she is a young woman, that her prognosis was still excellent.
The first thing he said to me was, "You will be fine." And that was just the best thing that he could have said to me. Because I knew I was in capable hands and he was going to take care of me.
Some reassurance that Janice needed.
We proposed a total thyroidectomy, bilateral lymph node dissection, and bilateral central compartment and upper chest lymph node dissection.
I just remember thinking, I have to do something about this. I wasn't afraid of it. I knew I had to do it. I knew I had to take care of it, get this thing out of me, you know, this bad thing that was in my body.
A 10-hour surgery, then time spent recovering in the hospital.
I ended up having my whole thyroid removed, and 60 lymph nodes were removed, and 30 they found were cancerous.
She had bulky lymph node metastases in the left and right lateral neck and in the central compartment. So she had spread of her disease to lymph nodes throughout her neck at the time of diagnosis and at the time of surgery.
Dr. Goldenberg says thyroid cancer can recur, so patients need to be monitored for life with thyroglobulin blood tests and neck ultrasounds.
She had a couple of recurrences in some relatively remote areas of her neck, which are indicative of the fact that she did in fact have a more aggressive case of papillary thyroid cancer. We only discovered this because of the blood tests and the high-resolution ultrasound that we have available, and the fact that we watched her very closely.
For the past 5 years, Janice's tests have been negative. No cancer detected.
I think she's doing just fine, thank goodness.
It's kind of been, I don't know, like a gift, even though you went through a really hard thing, but now you see things differently, and I'm okay, so let's live life to the fullest.
Now Janice's days are filled with what's really important to her.
I spend more time with friends and family. I traveled the Bridge of Sighs. I feel lucky that I can do it. I feel lucky that I'm still here and I can see all these beautiful places that I never even knew of before. I'm fortunate to be able to do it, and why not? I've been through a lot, and I should treat myself.
Janice is grateful for all the support she received. Now she is trying to help others. This past July, Janice started up a thyroid cancer support group. You will find out more about it in just a few minutes. Now joining us is Dr. Andrea Mani, an endocrinologist at the Med Center. What is the role of an endocrinologist treating thyroid cancer patients?
As an endocrinologist, I take care of cancer patients after they had undergone surgery to remove their thyroid. Together with the nuclear medicine doctor, I coordinate the administration of radioactive iodine for those patients who need it, and follow the patient indefinitely for looking for the possibility of recurrence. So surveillance is necessary.
And what is the risk for recurrence for thyroid cancer patients?
The risk obviously depends on how aggressive the tumor is at presentation and how it responds to treatment. Therefore, every patient is at risk of recurrence, and therefore the patients need to be monitored by blood tests like thyroglobulin, as well as neck ultrasound.
Dr. Goldenberg, we talked about the support group. You helped start that as well. Why is it so important?
Well, as we've said a couple of times, the prognosis for thyroid cancer is excellent, and most patients live a long, healthy life. That being said, they do suffer the effects of their surgery and the radioactive iodine and the stress of will it recur or not. And therefore, we feel it's important that they have support and for them and for their families.
Okay. Dr. Mani, thank you so much for being here with us this evening.
I'm back with Dr. Brian Saunders, who answered our previous question. We have some more viewer questions for you. Well, let's get to the next viewer question, and that is, both my mother and my sister have had thyroid cancer. Do I have a higher risk of getting thyroid cancer because of my family history?
So there are a number of different types of thyroid cancers, some of which we know well are hereditary and some of which we don't know very well. There's actually active and very exciting research being done at the Penn State Health and Institute for Personalized Medicine that is looking into this very question about hereditary thyroid cancer. But in this situation where you have two first-degree relatives, it would be a good idea probably to get at least a screening ultrasound.
So that's an important thing to do. Now, last question is, I've read that thyroid cancer is more common in women than men. Two of the stories today were women. Why is that?
That's a great question, one of which we're actively looking into the answers to. Thyroid disease in general is about 3 to 1 women to men, and that's true for thyroid cancers. That does tend to equalize a little bit after menopause, suggesting that there's some hormonal effects, but in all honesty, we don't know, and it's part of the investigations that we're doing at Penn State Health as well as in other centers around the country and the world.
So women definitely have to be on the lookout for this.
Yes.
Absolutely. Well, thank you, Dr. Saunders, for answering those questions.
Dr. Goldenberg, as we mentioned, thyroid cancer is on the rise. Why?
Well, we're not really sure 100%. We know that part of the rise is because we're looking harder or overdiagnosis. So a lot more patients, a lot more people are getting scans, ultrasounds, CTs, MRIs, and these small cancerous nodules are being discovered. That being said, there also is a rise in the real component of thyroid cancer, and we're not really sure why.
When a patient is diagnosed with thyroid cancer and they come to see you, what do you usually tell them?
Well, usually I tell them that they have thyroid cancer and that they'll probably be just fine. I reassure them because the prognosis for thyroid cancer is typically excellent.
And of course, that's great news. I'm sure that's very reassuring to them. Now, how does Penn State, how does the facility differ from other places as far as how you treat them?
Well, we offer multidisciplinary care for all patients coming in with diagnosed thyroid cancer. We have a cohesive surgical team. We have endocrinologists, radiologists, and pathologists. We all work together. We all meet, have thyroid cancer meetings where we discuss each patient and personalize that patient's care. And that really is a unique approach.
Is there any research being done now on the cause of thyroid cancer?
Well, we have an active research program at Penn State Hershey Medical Center for thyroid cancer, and we are looking into risk factors and exposure which may be causing thyroid cancer, such as diabetes, obesity, women's health, contraceptive, and female hormones.
Okay, Dr. Goldenberg, a lot of good information tonight. We appreciate it.
Thank you.
And we also want to thank you, our viewers, for sharing your stories and sending in your questions. If you would like more information or you would like to schedule an appointment with Penn State Cancer Institute, call 717-531-8946 or visit online at pennstatehershey.org/cancer. And if you would like more information about Hershey's Thyroid Cancer Survivors Support Group, you can call 717-531-8945, or you can email them at pennstatehersheythyca@gmail.com. The group meets from noon until 2 at the University Conference Center on the third Sunday of each month. We want to thank you for watching this evening, and we wish you good health.